CVS Part 1 Case 9.
A 69-year-old man with ischemic cardiomyopathy, chronic kidney disease and type 2 diabetes is brought to the ICU with fever, confusion, worsening dyspnea and oliguria for 12 hours. 3 days earlier, he developed dysuria, chills and progressive weakness. In the emergency department, he is hypotensive despite 2 liters of balanced crystalloid and norepinephrine is started. Due to worsening hypoxia and respiratory distress, he is intubated. Bedside ultrasound shows diffuse B lines, a plethoric inferior vena cava and a dilated left ventricle with poor systolic function. On examination, temperature is 39.1 degrees Celsius, blood pressure is 84/50 on norepinephrine, heart rate is 122, respiratory rate 28, oxygen saturation is 93% at FI 0.6. He is confused with cold, mottled extremities and delayed capillary refill. JVP is elevated, bibasilar crackles and bilateral pitting edema are present. Urine output is 10 ml per hour. Laboratory findings include WBC count is 21,500, lactate is 6.2, creatinine is 3.1, BNP is markedly elevated, troponin is mildly elevated, pH is 7.28 and HCO2 is bicarb is 16. Broad spectrum antibiotics are initiated. A pulmonary artery catheter shows CVP 19 mmHg, PCWP is 26, cardiac index is 1.5, SVR is 620 dynes, mixed venous oxygen saturation is 54%. Which of the following is the best next step in management? Administer an additional 3 to 5 liters of crystalloid rapidly. Option B, increase norepinephrine alone and continue fluid resuscitation. Option C, start dobutamine while continuing norepinephrine and ongoing sepsis management. Option D, initiate nitroprusside and discontinue vasopressors. Option E, administer high-dose loop diuretics as sole therapy.
So this is a case of mixed shock where there is septic shock and cardiogenic shock. Both the elements are there. So we need to address both the elements independently. The cardiogenic shock and the septic shock has to be addressed independently here. Now the things that are telling us about the septic shock in this case are the patient has fever, leukocytosis, increased lactate and peripheral vasodilation, which is reflected by a low systemic vascular resistance, which is 620 dynes in this case. Now cardiogenic shock, it's a low output failure here with a very low cardiac index and the other parameters which are confirming that there is hypoperfusion in this case. So addressing these two elements independently, we need to start an inotrope and a vasopressor to take care of both the elements. The vasopressor like norepinephrine is going to take care of the septic shock, which will divert the blood to the vital organs, and an inotrope like dobutamine will take care of the force of contraction, will increase the force of contraction and will lead the heart to pump blood more efficiently. So in this scenario, we have understood that when we get a mixed shock, we need to address the components independently. Now coming to the explanation of the options and exclusion of the wrong options and the selection of the correct option.
Option A is administer an additional 3 to 5 liters of crystalloid rapidly.
So if we administer crystalloids rapidly, it will add to the decongestion. Rather, we should do careful diuresis to decongest the heart, and addition of crystalloids will further congest the heart.
Option B is increase norepinephrine alone and continue fluid resuscitation.
So norepinephrine given alone will also not solve the issue, solve the problem, as we need to address the cardiogenic shock as well.
Option C is start dobutamine while continuing norepinephrine and ongoing sepsis management, which is the correct option.
This is the correct option, that will add one inotrope and norepinephrine to take care of both the elements, and the ongoing sepsis management with broad spectrum antibiotics should be continued.
Option D is initiate nitroprusside and discontinue vasopressors.
Again, if we initiate nitroprusside, which is a vasodilator, and discontinue vasopressors, that will lead to further more peripheral vasodilation and will lead to a decreased preload, and the congestion will further worsen.
Option E is administer high dose loop diuretics as sole therapy.
Administration of loop diuretics as sole therapy will also not solve the issue, as it will primarily lead to some decongestion, but it cannot help in managing the septic shock and the superimposed cardiogenic shock on that. Thank you.
Thank you.